Well, this is a case of the optic disc pit maculopsy. The allolam was stained with the ICG and then make a flap of the allolam. The foveal thickness is about 80 microns, so I performed the maculosphere peeling, and then I inverted the allolam flap of allolam to cover the pit and perform the fluid air exchange at the nasal part of the optic disc to keep the allolam in position.
So this is ILM flap for the optic nerve pit. Comments from the panel? David?
So I do there was a video I showed earlier, I do the exact same thing, but I didn't get to show you, is I add a fibrin sealant. So historically, I guess I've had a lot of experience over the last 20 years using, first it was Tecil, and now it's Evisil. And we just published this in OSLI 6 months ago, and a series of pits where it's a flap, then you put the Evisil on, it kind of holds the flap in place, and it also allows kind of a wound healing response to occur as well. So I think that's the exact same technique I do, but add the Evisil on top.
We have done around 8 cases of the ILM flapping in case of optic nerve pits, and it's a very promising result. 7 cases have done really good, except one which has a very large optic pit, and at that time when I tried to take the temporal flap and put it inside, it was not sufficient. So I had to go with the extra ILM harvest from the temporal side and then stuff it inside. It works well. In India, some have tried putting a scleral patch graft and plugging it in the optic disc pit, and then they say it works well. And few authors have said that there is some negative suction pressure, because whenever you put these plugs or anything, you see that it stays inside.
So the retina specialists are real experts to figuring out or finding something to stick in that opening you see in the back of the eye, either being a macular hole or optic nerve pit. I've seen ILM, I've seen capsule lens, I've seen scleral patch, amniotic membrane. You call it, they put it in there. And I think the issue, I mean, the ILM flap I saw Jose Garcia Arumi presented, I think about 1 or 2 years ago, and I think it's a very elegant technique because you just lift it over, it's very easy to put in. But my understanding was that it doesn't last, it does not stay. So when you follow up, it's not there. That's why they did the, Grazia Pertile showed that you actually do a scleral graft and put that in. It looks pretty horrific when you see that thing being put into the optic nerve. But going back to David, you want to comment?
I was just going to say, that's why I put the Evisil on.
Yeah, so that's the, many years ago, Brooks McEwen showed that the mechanism, or I think that's the idea, the mechanism is because over the valve you have some glial tissue that functions as a vent, as a valve. So the vitreous is pulling on it, opening it. So the key is to induce a PVD and relieve that pressure, and most of the times they close. Now I think we all agree that optic nerve pit is probably a spectrum of diseases. Not everyone is exactly like the others, but many times if you just sit tight and do nothing after the vitrectomy, that fluid goes away over time. But again, we have seen many tissues, and I think the key is if you put any type of adhesive over that optic nerve pit that prevents it from opening, that may expedite the resolution of the fluid. But I think most of the times, and this may take a long time, it may take 6 months, 9 months, sometimes up to a year, but amazingly the fluid goes away most of the times, and the patients look really good most of the times.